If you treat leg spider veins by microsclerotherapy, you know that brown staining is the complication patients ask about most frequently. In fact, on our training courses, brown staining after microsclerotherapy for leg spider veins is the complication our delegates ask about most frequently. They want to know the answer. For a patient who chose treatment to improve the appearance of their legs, a brown mark can be more distressing than the original spider vein ever was. So when a patient comes back with pigmentation and asks what cream will get rid of it, what do you actually tell them? Wouldn't it be great if there was a cream you could apply and it would get rid of the pigmentation completely? Does such a cream exist? In this video, I'm going to give you the facts about topical creams for post-sclerotherapy pigmentation so that you can answer your patients honestly and with authority. You may have heard the hype. I'm going to give you the evidence. This is part one of a two-part series based on a review I have written with my colleague Richard Oliver, which has been accepted for publication in the Journal of Sclerotherapy. This video covers topical agents only. Next week's video covers how you can minimize post-sclerotherapy pigmentation in the first place, because at the end of the day, many regard post-sclerotherapy pigmentation as an expectation rather than a complication. Let's get started, and be sure to stay to the end when I will give you my own personal opinion about topical creams for post-sclerotherapy pigmentation and my approach to brown staining in general. Let's get started. Why are there so many different creams for post-sclerotherapy pigmentation? To answer this question, let's consider the two main causes. The first is hemosiderin. This is an iron protein complex, and it is present in every single case of post-sclerotherapy pigmentation. When the vein wall is damaged, the red cells extravasate into the surrounding dermis, and macrophages process that hemoglobin down through biliverdin and bilirubin to hemosiderin. The second is post-inflammatory melanin. This isn't present in every case. Histological work by Bossart and colleagues examined 20 biopsies from patients with pigmentation, and they found hemosiderin in all 20, but increased dermal melanin in only 7 of the 20. Why is this important? Well, most conventional depigmenting creams target melanin production through tyrosinase inhibition. If the major component of post-sclerotherapy pigmentation is hemosiderin, tyrosine inhibitors will not produce a dramatic improvement. And this is the crux of the matter, and it explains why topical agents for post-sclerotherapy pigmentation produce such variable results. Because two pigments are involved, identifying which one is dominant is the single most useful thing you can do before choosing a treatment. In practice, topical agents are most effective where you suspect that melanin is the dominant pigment. That tends to be more likely in darker Fitzpatrick skin types, 3 to 6, where melanocytes are more reactive to inflammatory stimuli. If you suspect hemosiderin is the dominant pigment, a depigmenting cream is unlikely to make much difference. So let's go through the agents that come up in this discussion about creams, one at a time, and examine the evidence for each. Triple combination cream. This is the modern version of Kligman's formula, first described in 1975. The original formula was hydroquinone 5%, tretinoin 0.1%, and dexamethasone 0.1%. Contemporary practice typically uses hydroquinone 4%, tretinoin 0.05%, and a topical corticosteroid such as mometasone furoate 0.1%. It suppresses melanin synthesis, it speeds up epidermal turnover, and it limits irritation from the hydroquinone. It's widely regarded as the standard regimen for post-inflammatory hyperpigmentation. But here's the thing. This regimen has never been tested in a randomized trial for post-sclerotherapy pigmentation specifically. The evidence is extrapolated from general post-inflammatory hyperpigmentation research. That doesn't mean it doesn't work. It means we're applying a well-established principle from a related condition, not a proven PSP-specific treatment. Hydroquinone on its own has been mentioned in the pigmentation literature going back decades as one of the bleaching approaches used with variable success. Its mechanism, tyrosinase inhibition, means it is the most relevant option where you suspect a melanin component, not for pure iron-brown staining. Azelaic acid, Kojic acid, topical retinoids, and topical vitamin C all sit in exactly the same evidence category. They're supported by general dermatology and tyrosinase inhibition literature, but none of them has been tested specifically in post-sclerotherapy pigmentation. Azelaic acid and Kojic acid both inhibit tyrosinase. Retinoids accelerate epidermal turnover and help disperse melanin granules. Vitamin C is an antioxidant that reduces the oxidative conversion of tyrosine to melanin. The bottom line? Well, no topical agent has PSP-specific randomized trial evidence. What we have in this table is a well-established regimen for post-inflammatory hyperpigmentation in general, and it's applied to PSP on the reasonable but as yet unproven assumption that melanin component behaves the same way here as it does elsewhere. But we don't know for sure. There are two other agents that come up frequently in conversation, particularly recently with my colleagues at the British Association of Sclerotherapists, and I want to address them directly. Thiamidol is a highly specific tyrosinase inhibitor with mechanistic and clinical evidence in melasma and post-inflammatory hyperpigmentation more broadly. But it hasn't been studied directly in post-sclerotherapy pigmentation, and it sits in exactly the same evidence category as the agents on the previous slide. Plausible, mechanistically supported, but extrapolated from general dermatology specifically to sclerotherapy. Angiogel and similar hemosiderin-directed dermocosmetics are marketed for post-hematoma and post-procedural yellow-brown staining with claimed iron-chelating effects. I looked for independently verified PubMed index clinical trial evidence specific to a post-sclerotherapy pigmentation for these products, and I couldn't find any. That doesn't mean they don't work and they don't help. It means they should be discussed as commercially available products of interest, not as evidence-based therapies. I want to spend a moment on Deferoxamine Mesylate because it's often mentioned in the same breath as topical creams, and that's a little misleading. Deferoxamine Mesylate is a systemic iron-chelating agent. It's licensed for acute iron intoxication and chronic transfusion iron overload. It should be administered by intramuscular injection, intravenous infusion, or a slow subcutaneous pump infusion over many hours. It's not licensed for pigmentation of any kind. Its use in post-sclerotherapy pigmentation, whether as a subcutaneous injection or intradermal mesotherapy, is off-label. Off-label in the indication and off-label in the way it is administered. The appeal is obvious. Unlike everything else on the previous slides, deferoxamine directly chelates iron, so it targets hemosiderin, the pigment that topical creams cannot reach. The evidence is limited, but really interesting. Lopez and colleagues showed that in a group of 36 patients that were treated weekly by subcutaneous injections, there was depigmentation in a mean of 27 to 46 days compared with 150 to 255 days in untreated controls. A more recent case series by Melonetto and colleagues described 3 patients treated with monthly intradermal mesotherapy, 2 of whom achieved satisfactory lightening after 3 sessions, with the third needing a 4th session. Now that's a really useful signal, but it's a very small case series and one modest comparative study, not a randomized trial, and it should be read exactly as that. Before considering deferoxamine, we need to be aware of its safety profile. Recognized adverse effects include hypersensitivity and anaphylactoid reactions, injection site reactions, and with prolonged or high-dose systemic use, ototoxicity and ocular toxicity. Before prescribing and administering this treatment, patients should be carefully consented. It's not as simple as just applying a topical cream. We'll come back to deferoxamine in more detail next week, alongside the full staged management algorithm. So let me summarize what you can take away from this video and the evidence review on treatments for post-sclerotherapy pigmentation. First, post-sclerotherapy pigmentation has 2 causes: hemosiderin in every case and melanin in a subset. Topical agents only address the melanin component. Second, no topical agent, including the standard triple combination cream, has PSP-specific randomized trial evidence. What exists is extrapolated from general post-inflammatory hyperpigmentation and melasma research. Third, Thiamidol sits in that same category. Angiogel is a commercial product without independently verified specific trial evidence. Fourth, deferoxamine mesylate targets hemosiderin directly, which nothing else in this video does, but it's not a topical treatment. It's a systemic iron chelator used off-label. It has potentially serious side effects, and patients should be carefully consented. Fifth, identifying dominant pigment before you choose a treatment is the single most useful clinical step you can take. Next week, I will cover prevention strategies and the full staged management algorithm for established post-sclerotherapy pigmentation. And it's drawn from the peer-reviewed article Richard Oliver and I have written for the Journal of Sclerotherapy. As soon as our article is published, I'll provide a link to it in the description below. This review article has all the citations. Now, if you found this video useful, please consider giving it a like and sharing it with your colleagues so we can get the word out. And make sure you subscribe. That way you won't miss my next video. My name is Dr. Haroun Gajraj of the Vein Care Academy. Thank you for watching.